So to start with, let's talk about just some general incidents and talking about congenital heart disease and how prevalent it is in children in the U.S. and in live births that we see.
Okay. In general, heart disease or heart defects in babies occurs about 1 out of 100 births, so about 1% of the time. And those range from very simple defects that never require any sort of treatment to very complicated defects that may require emergency surgery or procedures right after birth. In general, the most common types of heart defects that we see would be something like a ventricular septal defect, which is a hole between the pumping chambers of the heart. And often those defects, even when we find out about them, will close on their own. So those may not even need surgery. And then the more complicated and more serious defects are much less common. But in general, the incidence of heart defects in babies, newborn babies, is about 1%.
Okay. I'm aware that we started doing screening for what we call critical congenital heart disease in all children in the United States about 2 years ago.
Yep.
Can you tell us a little bit about that and what we're searching for and trying to pick up on those screenings?
Yeah, absolutely. It's a really simple test and one that I think is important, and I'm glad that we're doing it now. And like you said, it's been going on for a couple of years. And in babies that are born at a hospital, what they do is they have a monitor that they can put on the baby's finger and on the baby's toe that will measure the oxygen in the blood as a percentage. So you and I probably have about 95 to 100%, which means all of the red blood cells are full of oxygen. And what they're looking for is something lower than that, or a discrepancy, a difference between the finger and the toe. And so if they find a level that's low for whatever reason, they repeat it to make sure it's just not an error. Or if they find a difference between the upper and lower half of the body, and then they repeat that, and if it still sticks around, then they give us a call, and we go over and we do an echocardiogram, a heart ultrasound, and just make sure that there's nothing wrong with the heart. There is what we call a false positive rate, meaning sometimes we get referrals for the echocardiogram, and it turns out that, of course, the heart's normal and there's nothing to be concerned about. And that just happens from time to time, but it's better to try and capture as many of those defects, however rare they may be, at the expense, of course, of sometimes doing an echocardiogram on a baby with a normal heart.
Okay. So what happens when they do have a positive screen? Like, what are the options for treatment if they're picking up some of these critical heart conditions in children?
That's a great question. A lot of it depends upon the type of defect that we identify. And it's obviously, if there's nothing wrong with the heart, nothing needs to be done, no follow-up needs to be done from a cardiology standpoint. But depending upon the type of the defect, if we were to find one where the oxygen levels were very low, where there wasn't enough blood going to the lungs, for example, they might need to be transferred to a hospital for a higher level of care. The babies might need to be given a medicine through an IV to kind of keep some of these arteries open and to allow more blood to go to the lungs. And then depending upon the specific defect, we'd have to discuss with our surgeon and with the other cardiologists what the best course of treatment is. In some cases, it may be surgery within the first few days or weeks of life.
Okay. What about if your child does get diagnosed with congenital heart disease? Is there some things that parents should be looking for besides the obvious treatment for the heart? Are there other associated problems that they should try to anticipate, or they can be proactive at getting out in front of the treatment?
Sure. Yeah. There are some defects, and again, some of the more complex defects that we see that can be associated with genetic syndromes.
Okay.
So as part of the evaluation, either when the family sees a cardiologist or later if they're referred on to see a geneticist, there might be some testing, some genetic tests to do to see if there are any genetic defects that we can identify. The most common one that's associated with heart defects is something called 22q deletion or DeGeorge syndrome, and that's important to know because that can be associated with abnormalities of calcium levels in the blood and temporary immune deficiencies in babies. And that can affect how we treat them. It doesn't mean that we wouldn't offer surgery or that they wouldn't do well over the course of their life, but it does affect the treatment outside of the heart itself. So that would be one thing that to keep an eye out for. The more simple defects, the more common defects are much less commonly associated with genetic syndromes, and so we don't often do a whole lot of genetic testing for what we call simple heart defects such as ventricular septal defects,
Okay.
like I had mentioned before, some valve abnormalities,
Okay.
and atrial septal defects, which is a hole between the top sort of venous chambers, the chambers that receive blood to the heart.
So if, say, a parent has a history of having a VSD as a child themselves, or a bicuspid aortic valve, some kind of more common congenital heart disease that we see, do their children need to get screened?
That's a very good question. For children, for ventricular septal defects, for the VSDs, for example, if the children are born and they're doing great and they don't have a heart murmur, we typically don't feel the need to screen, because those are common enough, and we don't really see that they're associated that closely with being passed on from parent to child. The bicuspid aortic valve is a little bit different because that can run in families, and excuse me, and over time, while a bicuspid aortic valve may function very well for years or decades, over time there are some issues that we can see pop up down the road in older childhood or adulthood, such as the valve thickening and degenerating and not functioning as well, or dilation of the aorta, which is the big artery that comes off of the heart above the aortic valve. And so we tend to recommend that all family members, first-degree family members of patients, people with bicuspid valves, get an echocardiogram at some point in their life to screen.
Okay, great.
That's a very good question. So in about 1 out of 100 live births, we see some type of heart defect. And when we put it in the context of all inborn defects that children can be born with, so brain abnormalities, intestinal or stomach abnormalities, bone defects, and that sort of thing, it actually is the most common congenital sort of inborn defect that we see. That's a very good question. We'd love to think that we're the only ones doing it, but no, the answer is that most hospitals these days, over the past years, have rolled out this procedure for screening, and the tools that are needed for the screening, as far as measuring the oxygen levels in the hands and the toes, they're at every hospital in America, and should be easily available.
And those guidelines were issued, was it by the American Heart Association? Or?
Yeah, I believe it was the American Heart Association that issued those guidelines. And the great thing about screening tests, there are a lot of screening tests that cost a lot of money and require a lot of resources, but this is one that the monitors that we use, aside from the thing that tapes on the baby's finger, it's reusable, and we can use it over and over, so it's very cost effective, I think.
When babies are born in the hospital, there's a couple screens that we recommend that all children get. So one of them is the congenital heart disease screening, which Dr. Taggart already talked about. A second one would be a hearing screen the baby gets before they go home. And the third one, also extremely important, is getting their newborn screen. So all of the states in the U.S. have some form of newborn screening program they do. It varies by state to state which diseases that they are looking for, and you can usually find that on your state's public health website for which things they're screening for. And then the last one is also recommended, is looking at a bilirubin level before the child goes home, knowing where the child's at in regards to how high their bilirubin or their jaundice level is, and so that you can watch and predict and help treat if need be to bring that level down to a safe level, because all babies will have some degree of jaundice. So those are kind of 4 total screening packages that we recommend that all children get before being discharged from the hospital, and all hospitals in the United States are following those guidelines, I would expect, because they're pretty national standardized guidelines.
As far as I know, with the Zika virus, they've not identified an association between the Zika virus and heart defects. And I don't suspect that they will. The reason is because the primary manifestation in a fetus, so an unborn child whose mother gets Zika virus, that we're concerned about is the microcephaly, or the small head, the small brain. And the development of the brain and the growth of the brain in the head it occurs later during fetal development than the heart does. So I suspect that the heart will have already been committed to its normal sort of genetic development, regardless of the Zika virus infection. I don't anticipate that we'll see an association, but I may be proven wrong. We just don't know yet.
That's why they're actively funding lots of research towards to figuring out how it's affecting the fetuses and transmission. So stay tuned. I think they'll have lots more information in the next year or two.